Good morning, and welcome to day 2 of this public meeting of the Physician-Focused Payment Model Technical Advisory Committee known as PTAC. I am Paul Casale, the chair of PTAC. Yesterday, we began with CMS leadership sharing their strategy for CMS and its Innovation Center, which includes the goal for all Medicare beneficiaries with Parts A and B to be in a care relationship with accountability for quality and total cost of care by 2030. That is one reason we chose to explore how population-based total cost of care models as our theme-based discussion for a 3-meeting series this year. We had a variety of experts from academia and payers to one of our own PTAC members, Dr. Larry Kaczynski, provide their insights on how we can move toward population-based total cost of care models. We learned what the research shows on the impact of population-based models and episode-based models on quality and cost, and where further information is needed. Our guests discussed how population-level efforts can address health equity and what some of the best practices are for improving affordability for patients. We also heard about options for defining total cost of care, state-level innovations, opportunities to align across multiple payers, and how to structure these models so that specialists can participate meaningfully. Also, the team of PTAC members that work with staff to prepare the agenda and background materials presented information about relevant key issues and how proposals submitted to PTAC incorporated elements related to total cost of care. Because we might have some new folks who weren't able to join yesterday, I'd like the committee members to please introduce themselves. Share your name and your organization. If you would like, you can share a brief word about experience you may have with population-based payments or total cost of care models. Since we are meeting remotely, I will cue each of you. So I'll start. I'm Paul Casale. I'm a cardiologist, vice president of population health at New York Presbyterian, and I lead New York Quality Care, which is the accountable care organization for New York Presbyterian, Weill Cornell, and Columbia University. Next, I'll turn to Lauren.
Good morning, I'm Lauren Harden. I'm a nurse and senior advisor for the National Center for Complex Health and Social Needs and the Illumination Foundation. I spent the last 20 years doing care management design under many different value-based payment options and currently work on co-designing models for complex, underserved, under-resourced populations.
Thank you, Lauren. Jay?
Hi, my name is Jay Feldstein. I'm president and CEO of Philadelphia College of Osteopathic Medicine. And prior to that, I spent 15 years in the health insurance industry, in both commercial, Medicaid, and Medicare.
Great. Larry?
I'm Larry Kaczynski. I am a gastroenterologist, having practiced for 35 years. I am the founder and chief medical officer of Sonar MD, a value-based transition company in the gastroenterology space.
Thanks, Larry. Josh?
I'm Josh Slough. I'm a physician and faculty member at the University of Washington School of Medicine, where a part of my work is studying and evaluating the impact of payment models on patient and population outcomes. In addition, I'm the enterprise level medical director for payment strategy for UW Medicine. And in that role, I'm fortunate to provide leadership to a number of payment models and arrangements, including total cost of care population-based models.
Great. Walter?
Good morning. I'm Walter Lynn. I'm an internist and founder of Generation Clinical Partners. We are a medical practice focused on caring for the frail elderly in senior living and helping senior living organizations transition into value-based care.
Thank you. Lee?
Good morning. I'm Lee Mills. I'm a family physician, and I'm Senior Vice President, Chief Medical Officer of Community Care of Oklahoma. We operate a fully capitated model across both commercial and Medicare Advantage spaces.
Thank you. Chinny?
Hi, I'm a family physician by trade and practicing for about 15 years. Currently serving to lead Walmart's health clinic outreach and enterprise. And prior to that, I served to lead the value-based care business line for a large medical group implementing across the risk spectrum, as well as practicing clinically within that risk spectrum.
Great, thanks. Angelo?
Angelo Sinopoli. I'm a pulmonary critical care physician. Until just recently was the chief clinical officer for Prisma Health in South Carolina, where some of my responsibilities were our clinically integrated network of about 5,000 physicians, and also was the founder of the Care Coordination Institute. My present role is that of Chief Network Officer for Upstream Healthcare, which is a risk-bearing, value-based organization that partners with primary care docs.
Thank you. Bruce?
Hello, I'm Bruce Steinwald. I'm a health economist in Washington, D.C. I have 50 years of experience in health economics and health policy in academic, government, and private sector settings.
Thanks, Bruce. Jennifer?
Good morning. I'm Dr. Jennifer Weiler. I'm the Chief Quality Officer of UC Health Denver Metro area. I'm a tenured professor at the University of Colorado School of Medicine, and I'm co-founder of UC Health Care Innovation Center, where we partner with digital health companies to grow and scale their solutions to improve the value of care. My academic area of interest is payment policy, and I was a co-developer of an APM that was evaluated by this committee prior to me being a member.
Great, thank you. So at this time, we'll take a short break to set up for our first listening session, which the Vice Chair, Lauren Harden, will moderate. So please join us at 11:15. We have a terrific group of guests scheduled for the day. Thank you.
Welcome back, everyone. I'm Lauren Harden, Vice Chair of PTAC. We have a fantastic group of experts here to present on issues related to population-based total cost of care models. We will have our first two presenters present, and then our committee members will have time at the end to ask those two presenters questions in the Q&A session. Then our remaining three presenters will present, and our committee members will have time at the end to ask each of those presenters questions in a final Q&A session. You can find all of the presenters' full biographies on the ASPE PTAC website, along with other background information materials for today's meeting. Presenting first, we have Dr. Sherry Glied, who is the Dean of Robert F. Wagner Graduate School of Public Service at the New York University. Please begin.
Thank you very much, and thank you so much for having me here. I'm going to be speaking at the 30,000-foot level, so maybe it's a good way to frame some of the conversation that comes today. Next slide, please. So, our goal here in general is to reduce the cost of care while improving or maintaining healthcare outcomes. And the way that we think about doing that is to do things like reducing duplication or monitoring and connecting people so that they avoid increases in severity in the future, or increasing prevention efforts to avoid future care. That is, these are all strategies that focus on the quantity side of the medical cost conundrum. If I were talking about something that was not Medicare, I'd be spending a lot of time talking to you about prices. Since we are talking in a Medicare context, the focus here is around reducing quantities or optimizing quantities. I think it's really important to keep those two ideas very distinct, because a lot of the work around cost containment is around the price side, and your goals here are really very much more on the quantity side, and that I think is an important distinction. Next slide, please. So we have long thought about this as economists as being about fee for service. The reason that we're not getting where we want to be on the cost and quality side is because all of the things that we'd like to do around preventing unnecessary care, avoiding duplication, monitoring, all of those things are disincentivized under fee for service, because the more you do, the more you're paid, whether the care is necessary, whether it could have been avoided. And that's why we've moved to this alternative payment mechanism story in the first place. So this is all old history, and you know this. Go on. Next slide. But okay, there is a reason we had fee for service, and it's always important when you're moving away from something to think about why it existed in the first place. And there are fee for service has some really big advantages in terms of paying people. It's really easy to monitor performance. It's really easy to know whether something has happened because a payment is clearly tied to a specific patient and a specific process. You can see if you are an administrator or a bureaucrat, whether that process has happened, whether the patient has been seen. Second, it allows maximal choice by patients of their provider. So it is the best system if you're just going to let people go to see whoever they want. That is an attribute that is highly valued by patients. And so fee-for-service, continues to exist when you think about out-of-network payments, even in the private sector. If we think of people going out-of-network in Medicare, we retain fee-for-service in situations where people are going to any provider they like. Third, and this is going to turn out to be very important, it automatically risk adjusts. If you're dealing with more severe patients, you get more money. Patients who use more services generate greater payments. And in normal times, and like we're coming out of non-normal times, but I think it's important to remember that so far our track record is that they happen every 100 years. Fee-for-service leaves providers with very little risk. The more they do, the more they get paid. If they do less, they get paid less. They control the amount of risk that they face in their operations. These are very important, valuable properties. Next slide, please. So here's a good question for all of you focused on changing payment systems. How many of these 9 countries, which we might think of as our, peer countries in healthcare, but who run their healthcare systems at much, much lower cost, right? We know this, and generally have higher quality outcomes. How many of them use primarily fee-for-service to pay outpatient providers, outpatient physicians? Anyone want to guess? Anyone? Write your own number down on the panel to see whether you're right. Ready? Okay, let's reveal. Turn the slide on. Next slide. Hit the click button. All of those countries are using basically fee-for-service in their healthcare systems to pay outpatient providers. That is the standard way that they're doing it. Next slide, please. And likewise, we talk a lot about global budgets and capitated payment even in the hospital sector. So how many of these countries are using primarily global budgets to pay their hospitals? Again, do your best guess. Go forward. Let's reveal. Really just Canada and Sweden. Everyone else is essentially using output-based payment of the kind that we are trying to move away from as a way to pay their hospitals. So I don't say this to justify fee-for-service. That's not what I aim to do, just to say that its strengths are pretty big. That's why lots of countries are using it. That's why they've been used in the past in history. Next slide, please. So let's think about moving away from fee-for-service to alternative payment mechanisms. Let's move to a capitated, bundled, flat payment component. That's going to generate a new set of problems. We have a much higher burden of monitoring. It is better to measure value than volume, but it's a lot harder to measure value than volume. That's just the reality. You have to assign patients to providers. And if you're assigning patients to providers, it can create, doesn't necessarily, incentives for providers to offload the work they do and the cost of that work to other people. We've seen that, for example, when we moved to managed behavioral health care, which was the first big move into managed care within behavioral health. Behavioral health carve-outs covered talk therapy and they didn't cover pharmacotherapy. And so we saw these carve-outs essentially pushing patients towards their primary care providers who provided them with pharmacotherapy that wasn't covered under the contract. Likewise, and in a sort of meta sense, there's been this big push to bundle payment for post-acute care. And we have seen that that works and that there's reductions in the cost of post-acute care, but it may shift the burden of care to families and informal caregiving that we are not measuring. And in fact, it probably does because we're discharging people home with fewer services. That's not necessarily a bad thing, but we need to be aware of it. Next slide, please. We need a way to risk adjust because if we don't risk adjust, providers are incentivized to avoid the sickest patients. Risk adjustment, I first worked on risk adjustment in 1992. This is a miserable, difficult problem. Every risk adjustment system creates other perverse incentives. Right now, the ones we have create enormous incentives to overdiagnose people, and these incentives are pervasive across the system. And even after you risk adjust, you have to think about the risk that providers take on when they participate in these systems. And that leads us to move to voluntary participation because it's really hard to force providers to take on risk if they don't want to. And it leads to this multiplicity of models. If you have a lot of different alternative payment models, you are necessarily going to spend more money. Why is that? Because there's a lot of variability in structure and cost of provider organizations. So each organization can select the model that works the best for it, which means it gets the most revenue relative to cost. And that is going to mean that it's going to capture savings that would otherwise accrue to the Medicare program. So each organization has some payment model that would most perfectly fit what it's already doing. And if you move to that payment model, Medicare is going to lose money. It's also really hard to accurately assess the performance of many alternative payment models because of the selection problems at the patient and program levels. Next slide, please. So the underlying problem is really tough. A lot of recent economic research looks at the level of inefficiency in the healthcare system and says, you know, it's actually not that bad. There isn't that much inefficiency. We aren't as much of a mess as we think. We're just as inefficient as the rest of the economy. That means there's lots of reasons to improve processes, just as there are lots of reasons to improve processes in cement manufacturing, which is one of the ones that people look at, and you know, coffee shops. But these problems are not more pervasive in healthcare, and that means it's not so easy to fix them, and it's easier to generate positive financial returns by manipulating incentives than by doing really hard work that might improve care. Because it's not like it's low-hanging fruit. Getting to improving care is going to be really hard. Manipulating financial incentives is often pretty easy. Next slide. So now we come to this idea of total cost of care. And I have to say, I'm on the board of the Milbank Fund, which has been thinking a lot about total cost of care. And one of the things I've learned about it is that everybody uses that term to mean something different. So I don't know exactly what total cost of care is, but I think the general idea of it is that the unit of analysis is very broad. The best established example of it is Maryland, where you basically take the entire Medicare system, the entire healthcare system, and you look at the cost of the total cost of care. There are other models at the employer level. I think key features of what this ought to mean is that the population is not discretionary. It is not assigned. It is the full population of some unit that is independent of the choice of plan, or there are no decisions that are made around healthcare that are around the population that is being considered for total cost of care. So an employer might think about all employees in the firm, or a state might think of all the residents in the state. If you do that, you don't need very sophisticated risk adjustment. You probably can just use age and sex because you're actually looking at the total cost of this entire population. And ideally, you measure all aspects of the cost of care. So you want to think about the services that are paid for by Medicare. You want to think about all beneficiary out-of-pocket payments. You also probably want to think about things like informal care, because if what we're doing is shifting burden to informal care, at least we ought to know that that's what we're doing, whether it's the right thing or not. So some examples going forward. Next slide. Maryland is doing it, looking at Medicare beneficiaries, and several states have done it to develop cost growth benchmarks as a step towards further regulating their healthcare systems. So Massachusetts has a total cost of care measure, Connecticut has one, Oregon has one, Nevada, New Jersey, and Washington are building these. Yes, next slide, please. So it's a management tool. It's about selecting, not avoiding selection, risk adjustment, assignment, but it is not an incentive program. It is a monitoring and management tool that the incentives sit within. Do I have any more slides? That's it. Thank you.
Thank you so much, Dr. Glied. That was very interesting. Next up, we have Karen Holt, who is Vice President of Cooperative Health Systems. Please go ahead.
Slides will be up in just one moment. Thanks. Takes a minute to transition.
My personal passion has been the opportunity to work with providers and really help them become successful in managing the care of patients. Good providers who want to do the right thing but don't always have the right tools and technology to be able to get them there. Today, the goal of my presentation is really to talk about two specific opportunities to improve PCP's ability to successfully manage care coordination in patients. Next slide. So Cooperative Health Systems has been in operation since 2011. We have supported $475 million in savings to the Medicare Trust Fund, quality and clinical programs for physicians. We have 15 different programs currently today in 22 different states. We're in MSSP, direct contracting. We have 3 IPAs and Maryland a CTO program. We are supporting over 2,000 providers, independent providers, and 160,000 Medicare patients. Again, the goal of this is really what are we doing to make sure that we're supporting those providers who are independent and being successful in the opportunities of growing and changing medicine. Next slide. So as many of you know, the administrative and clinical activities of moving value-based care are overwhelming to providers. Increasing financial pressures for the cash flow challenges, rising costs, technology requirements are burdens that pushes many providers into becoming employed. When we see providers become employed, we actually see a change in they lose their autonomy and for how they practice and care for patients, as well as we know that this change is changing the passion for those younger generations to actually move into medicine. So again, who are we replacing our providers with, our independent providers? Cooperative Health Systems, is partners through the ValueBased Value Coalition, utilizes the Medicare programs to support providers really to be able to move through that risk continuum, right? So providing tools, technology, hands-on training, and clinical program implementation to support patients when and where they receive care outside the practice of the 4 walls of providers to really be able to drive that value-based care. Next slide. Population health management is the management of patients in all care settings, right? And the coordination of the care requires that we know where patients are and at all care levels. In addition, the successful management of patients with chronic conditions requires that care is well coordinated between providers, patients, and the care team. And this has been a challenge for many, many years. It is not unknown to this organization or to others. But what we do know is that the lack of care coordination costs, the Medicare billions of dollars of wasteful spending for avoidable complications and hospital readmissions. As well, we all know that care coordination is known, I apologize, my computer is dinging. Many hospitals, the new requirement for CMS to actually be able to, the CMS ADT rule is requiring that those hospitals are sharing ADT fees. The challenge with that is that we have providers and groups who are sharing data, but it's not really actionable for those providers. And so we know that they're sharing where a provider can log into a tool, they can download those patients who have admitted into their hospital. And so, gosh, we hope that that patient is remembered who their PCP is at that time of admissions to really be able to add and know the name. Again, so where we see that opportunity, it's still an additional burden in requiring these providers to log into a tool and be able to know where their patients are, instead of being able to have the opportunity to use a technology that's out there with true algorithms and being able to lift this burden off of providers. As Medicare looks to move more providers into value-based payments, utilizing ACOs as that glide path, we're looking for CMS to support the opportunity to recognize ACOs and IPAs into the payer definition, instead of just saying it's a provider who needs to be able to know when their patients are there, utilizing these organizations just like they are with health plans, recognizing ACOs and IPAs as being organizations that healthcare providers, hospitals will actually share that data with directly so that we can support them. Additionally, we're looking for, it's just not really the hospitals, but really how do we grow this opportunity for ADTCs to grow into home health and SNFs. We know that there are organizations like Experian and Patient Teams that are moving into this opportunity that are using algorithms, allowing us to use messaging to be able to devise programs so that we're not just communicating with one source, but using real-time data messaging so that we can send messages to multiple places. Let's send it to the hospital, the hospitalist, let's send it to the home health care company, our care team, the PCP, and outpatient specialists that we know looking at through claims data that allow for a true care coordination so that all parties know when that patient has admitted into a facility. An additional enhancement would be to really support those, again, and not just the hospitals, but really using a tool that allows those algorithms. It is one thing to say a messaging is that we're just sending an ATT feed, but again, that opportunity for real-time data is really the care coordination that allows for us to truly care for those patients. So not just requiring for hospitals to participate with those organizations, but allowing the ACOs and IPAs to be a part of that, just like they are with the health plans, right? Touching the right patients at the right time and really getting that care coordination. Next slide. So this is the CHS core model. It's designed, and its design is really to support providers for what's happening outside of four walls. Again, the point behind this is that really our teams, as for those Medicare opportunities through our MSSP or direct contracting or other type of state programs, the opportunities that we're really trying to support those providers and what's happening outside of four walls of their practice. And again, making sure that we're getting that data back to those providers. But really that enhancing the practices and their care coordination opportunities. Tools are important, but really it takes people touching people. And so where we're providing the opportunities for a practice, an independent provider may not be able to afford someone to go to a patient's home, that opportunity that we're allowing for them, really we need the right level of data. So we know that the significant challenge for us touching the right patients at the right time is the patients who have the highest chronic conditions. They're moving a lot, they don't have the right same phone numbers, there's a lot of changes that are happening there. And so that data that may be in a practice is not always accurate for us to be able to outreach to them. And so really looking for some opportunities for enhancement to that, again, that ADT feeds for hospitals when a patient is admitting into those facilities, that they're sharing that level of data with the hospitals. How do we make sure that those providers are getting that communication back where that patient who has 11 different chronic conditions may not have shared with, have been back to see their PCP in the last 6 months, but they have shared their current address and phone numbers with the hospital system. How do we make sure that that data is actually shared with those organizations, right? Making sure that we're touching the sickest patients and an opportunity to be able to manage their care. Next slide. Oh, great. So thank you for you guys for your time today and opportunity to share with you those opportunities to grow these programs and opportunities to increase the care coordination in our ACOs and our IPAs. Thank you.
Thank you so much, Erin. Very interesting presentation. Now we have about 10 minutes to ask questions. I want to open this up to our committee members. We have an opportunity to ask questions of Dr. Glied and Karen Holt. Please go ahead and please remember to unmute yourself as you come forward with a question.
Dr. Glied, it's always a dash of cold water when we look at these international comparisons and realize that what we're attempting to do here is rather contrary to what's done elsewhere. I wonder, though, if it's worth making a distinction, especially when we look at fee-for-service and how sticky it is, how hard it is to get providers to be willing to unstick themselves. We make a distinction between how a plan is paid and how the doctors are paid. And can we accomplish much of what we want to do by focusing on the plan as opposed to the individual provider?
So certainly, I think that is, well, first of all, plans are almost always paid by some form of capitation, right? We pay them a premium, and that's the way we've always paid them. Nobody pays health plans, I think, fee for service, although if we make our risk adjustment sufficiently granular, we may almost wind up doing that. But hopefully that's not what we're doing. And I think in those countries that have competing health plans in other countries, they also pay on some form of risk-adjusted capitation. I do worry a little bit that our risk adjustment methods generate some really perverse incentives for the plans, and that's something to worry about. But I think I am with you. I agree. I think that focusing a lot on plans and thinking about letting the plans figure out how to manage within themselves has a lot of positive value. One of the things that I think we have learned is that these micro payment incentives at the level of the provider may be a lot more trouble than they're often worth, and that management in the more conventional sense may be a better way to address some of the concerns that we have. Management, including things like buying better data systems and implementing electronic medical records to avoid duplication of care. So I think there are ways to do this. Plans also have more leeway to pick and choose which providers are in them and to look at practice patterns. So yeah, I guess the answer is yes. We economists.
Dr. Glied, thank you for a great presentation. A question, CMMI has spent a lot of time thinking about, how to engage specialists in total cost of care, larger population-based models. I'm just curious, in your thinking, whether the approach should be, create this population-based models, and then under that, the providers and others will sort out how to engage the specialists within that, or having more prescriptive models for particular specialties will be a different path for engaging specialists. I'm just curious if you have thoughts as to which approach might be more effective.
So let me sort of divide specialists into a couple of categories. I think there are a lot of specialists whose interactions with patients are very episodic and time limited. And they're going to see a lot of patients and they're not going to establish relationships with them. And their referral patterns are going to be from all over the place. So I think in those circumstances, trying to establish complex payment mechanisms for them may just be very costly in terms of the selection consequences. I think it's actually really hard. I think there are other patients who have ongoing relationships with other providers, other specialties who have ongoing relationships with patients that last for a while, where you might think that a single payment covering a scope of service, think about OBGYN, right? So you've got a very, very clear path. You have, you're covering this person for, let's say, for a year, and we expect certain things to happen. We have a good sense of what we're looking for. Monitoring is relatively easy. There's a place where I think you have a specialty care scenario that you could think about on its own, sort of sitting separately, having an alternative payment mechanism for. And I think, there's a lot of things that fall between those. And as you are on that continuum, I guess a couple of things I would say is, think about how much you are concerned about the downstream communication and interaction. So to what extent is this thing wholly within the province of the specialist, and to what extent is this an interaction across the system, and what incentives and challenges are injected by having those interactions? So do you want them to happen more or less? Do you want your cardiologist to be referring people back into primary care more, or do you want them to be taking on care more? And those sort of subtleties are gonna color how you think about the alternative payment mechanism there. And whether you want to do it entirely from, well, let's just give the primary care doctor the capitation and let them figure it out with the specialist, or let the health plan deal with both of them, or is it actually worth coming up with a separate alternative payment mechanism for, say, a cardiologist who's in regular contact with a patient? But it's very granular in that way.
Great, thank you.
Very helpful. Karen, I'm very curious as a follow-on question to that. What have you learned about in practice about bridging those relationships that is really key and really makes it a very effective system?
We do have a few of our ADT providers that are providing us notifications through for SNF, home health, as well as in the hospitals. And what we found is when we're comparing the patients who are admitting into facilities where we have those notifications, that continuum for us and being able to manage that patient all the way through, that we see a higher success rate in making sure that we're managing the readmission. When we know that they were in the hospital, we know where they went to a SNF, we can make sure that we're supporting that they get to the right care at home to make sure that they're not readmitting. And that success rate is twofold in being able to make sure that we're managing the cost of that patient. So really looking at that opportunity to be able to grow that initiative for the CMS ADT fees is it's not just the hospital, but let's also make sure that that algorithm and being able to have the tools and technology to really be able to support, it's not just let's go look for the patient. Let's make sure that there's automation in place. We're in a world of technology with artificial intelligence. Let's make sure that everybody knows at the same time by being able to write the right type of messages. So we know that it has been successful in really managing that care and keeping readmissions from happening and truly unnecessary readmissions.
I'd like to ask a question of Karen. I enjoyed your presentation. How do you maintain patient engagement in your care coordination? And how successful have you been?
So Howard, it's truly in our manner, the reality is that we can only touch a certain level of patients, and how we're keeping them engaged is through those educational opportunities. It's what we're doing with our providers and a mass opportunity to be able to send out education for disease management outside of what's happening in the practice, but really looking at how can we touch those high chronic conditions. And so there's only an opportunity to manage a certain level of patient at these areas. And so it is using our care coordinators, outreaching to them proactively before they're admitting, using our tools to be able to, what we call, percolate, who has the highest opportunity of readmissions by looking at their data and making sure that we're proactively getting them into educational opportunities, hoping that we're going to teach them about how to manage their diabetes, manage their ESRD. Are they on that continuum that they're moving into ESRD, to outreach to them to get them to the right level of care?
Thank you.
We have time for one more question. Glied, I'm very curious how you think about managing carve-outs in value-based payment.
Managing carve-outs? So, is that, the audio is funny. So I think the total cost of care vision is actually really important there, because carve-outs do have these incentives to shift care back into the main contract. And we definitely observe that. That incentive is strong. And wherever it's possible to do it, you can expect the carve-out to be going there. So, I mean, some of this is about, who is managing the full contract and how are they monitoring those places where you might see something happening under the carve-out. A lot of this is just keeping your eye on the ball and being really thoughtful about monitoring the full population and not just that aspect of the contract. So if I think about this total cost of care idea really as being sort of an overarching monitoring tool, right? Why are my costs not going down when the carve-out seems to be spending less money, right? The carve-out says that they're spending less money, but my costs are not going down in total. So what's happening here?
So helpful. I want to thank both of you for this rich conversation and information. We really appreciate you joining us today. Our next presenter, we're going to move to the next section. Our next presenter is Belinda Rutledge, the Chief Corporate Affairs Officer at Upstream. Please remember to unmute yourself and please go ahead.
Great, thank you. Well, first of all, I'd like to thank PTAC for inviting me to present at this session. I feel very honored to have the opportunity to share my thoughts and experience with this group. Just for background, I'm a nurse practitioner, and was a health system CEO for 15 years before Rick Gilfillan and Don Burry persuaded me to come into CMMI as a founding leader with CMMI. I was one of the leaders that helped write the Bundle Payment for Care initiative, so I never know whether I should apologize for that or not. I was most recently the EVP of Federal Affairs for America's Physician Group, where they have over 300 practices with 200,000 physicians that are committed to value-based healthcare. I interacted with many of those practices and began to understand firsthand their challenges in trying to implement total cost of care risk-based models. Just a month ago, I joined Upstream, which is a global value-based risk organization that is focused on supporting primary care through this transition. My presentation will focus on the barriers that are found in the adoption of total cost of care model focused on the primary care practice. So with that, if you could move to the first slide. So the first slide sort of talks about Upstream, 3 components of it. And this is from my experiences that working with APG over the last 4.5 years. We have embedded pharmacists and care coordinator, nurses physically in the office, and we also have extended services such as integrated pharmacy that can dispense it with home delivery. Many of these patients with chronic disease, as you know, medication and medication adherence is really a problem. The physicians get guaranteed advance payments for quality. These payments start where they're at from a quality perspective. So if they're at a 4-star now, we pay them a certain amount, and as they move up, we expect them to be at 5-star or 4.5, probably within 6 to 7 months. We take all the contract risks through substantial capital investment. We feel comfortable with that because we have a model that we think is very successful and has been shown to be successful in the areas in which we have implemented. We have some technology that, of course, goes ahead with it, and we have seen significant improvements in patient outcomes and satisfaction with this model we're implementing. So next slide. So the next, I'm going to talk in terms of the barriers that I have seen in talking to hundreds of practices over the last 4 years in terms of adoption in total cost of care. As we recognize, 70% of Medicare beneficiaries have at least one chronic disease, and they account for 95% of the Medicare spend. However, most of us in the industry, including myself as a health system CEO, really focused on the specialist and really focused in the inpatient. Thus, primary care is the engine behind care transformation, but we have not in this country put dollars and resources into primary care. The adoption in value-based models has been very slow with primary care. And in fact, it has been the specialists that sort of have been knocking on CMMI's door in terms of getting episodic payments. The primary care physicians have been somewhat reluctant to enter value-based model. Now, over the last few years, we've seen that change because there have been aggregators that have come forward in terms of helping them support the risk involved. So the barriers can be put into 4 categories in my estimation. The first one is financial. The second one is our current payment models. The third is the lack of integrated team approach. And the fourth is the adoption of technology. So the first one, and both Sherry shared with this, is the losses of taking on total cost of care and having downside risk goes straight to the personal income. So if any of us really believed in something and we wanted to do it for our patients, but we had a worry that it would actually impact our personal income and our family's income and our ability to provide resources for our family, we would probably be reluctant with that. And that's what we're seeing. Second is when you look at their percent of business, the traditional Medicare percent of business for most of primary care practices is only 15 to 20%. So you're talking about taking a personal risk on your income on a small piece of your business. Even if you may philosophically believe in it and not believe that fee-for-service is the way to go, but to take on that risk for a small amount of your business is very, very disturbing. Also, we don't have a proven care model. It's not like clinical practice in which there's best practice standards and they follow them. In their estimation, everything seems to be experimental. We know some things work in terms of decreasing post-acute care, but in terms of really knowing that if I follow A to Z, it's going to make a difference in terms of the overall utilization in that patient, they're not sure that that is out there. And so that makes them feel uncomfortable. And there's the cost of the initial infrastructure. For them to enter into it, they need the cost of the initial infrastructure. Now, CMS has tried to overcome that by putting some PMPMs in it on the front end. But again, it's not like someone hands you $1 million or $500,000 on the front end to set up care coordination teams. They're going to give it to you on a PMPM, but for you to be effective, you've had to develop a team approach. The next is the fee for service. And Sherry was talking about this. The fee for service is the underlying of everything. And for the exception of a few codes, in which I will be talking about, it represents billable time from a work done by a single provider. And so it is not set up for team codes other than care coordination, management codes, TCM, transition care management, advanced care planning. Those kind of codes are set up as team codes. For the most part, our fee-for-service codes are the work done by a single provider. And even the advanced ACO models like ACO REACH, how they set up the capitation is they take your fee-for-service codes that you have embedded, that you send no claims code into the MAC to determine what your capitation amount will be for the next year. So we're saying we want to get away from fee-for-service, but fee-for-service becomes the infrastructure of how we build the new model with capitation. This year, I can give you a good example of how suddenly we're doing both things at the same time. We're saying, CMS is saying, I really, really support value-based. We need to move away from fee-for-service. However, there is a code called a split visit code, which is if a physician is seeing patients in a facility and they're working with a non-provider practitioner, like a PA or an NP. Nowadays, what they modified the code. And so the code is now put in at who spends most time with the patient. So if the non-physician provider, the NP and PA, spent more time with the patient, then they put in the code at 85% of what the code would be, the E&M code. If the physician spends the majority of time with the patient, then it's put in at 100%. But they're working as a team. They're working as a team. The split visit code decides whoever spends most time with that patient and does not recognize the team approach. So we continue to say we want to get away from fee-for-service, but everything we have is built on individual clinical encounters for an individual provider. Second, we have an inability to connect the dots between coordination of care codes, CCM, TCM, remote patient monitoring, advanced care planning. These are rarely used by the primary care practice, rarely used. In fact, I asked one of my friends, has one of the largest primary care practices in an area, very complex patients. He's very experienced and he really believes in value-based. And I asked him, how many times does he bill under CCM? He says not a single time. He does not bill at all under CCM. And I asked why. And he says, because it seems so complex. There's so many requirements to bill under that. So in fact, CMS increased the rates for CCM to improve adoption. And so the workforce shortage has continued to limit the use of that. Then the next is the adoption of technology. We're having difficulty in independently applying technology. The practices modified their face-to-face interaction into virtual during the pandemic, but they continue to lag in the adoption of new technology. So next slide. I'm going to go through quickly in terms of the solutions. The first solution is to increase incentives. We need the development of more independent primary care groups. We need to look at tax or financial provisions to help them set up their practices. We need to engage patients as partners to develop compacts and contracts with those patients in which patients sign saying, I agree to this care plan. And this, as a physician, is what I am supporting. We need to reduce regulatory requirements. We get waivers through total cost of care models, but they're burdensome in terms of documenting. We need blanket waivers with minimum burdensome documentation. We need the funds to address social determinants of health, and we've talked about different ways to do that. We need to minimize the risk by having the benchmark modified for the high performers. They did that in Pathways to Success. They have a greater weight on geographic with the high performers. However, the most you can get is a 50-50 weight. We need education and technical assistance programs, including a central repository for independent docs to go in and identify best practices. And we need financial support for them to develop or buy analytic tools as independent physicians. And then last, we have to overcome the inertia. I wouldn't say lower the fee-for-service schedule, I would say adjust it. So we accelerate the movement to value. Maybe go back and relook at that split visit code and say, if you're in a risk-based contract, we're going to look at it in total and you'll get 100% if they're working together. And then strengthen the architect of the MIPS program. The MIPS program, as this PTAC is aware, has become very, very minimal in the impact to move people to value. And most of it is because there's very little penalties and everyone uses the uncontrollable circumstances. And the 5% advanced APM bonus goes away December 31st, 2022. Congress is aware of it. They would like to make a change and continue it, but we must maintain that. So with that, thank you.
Thank you so much, Belinda. That was very interesting. Next up is Christina Severin, who is president and CEO of Community Care. So, Christina, please unmute.
Please unmute and. Can you hear me okay?
Yes, we can hear you.
Thank you. Thank you for having me here today. Happy to back cleanup. As introduced, my name is Christina Severin. I'm the president and CEO of Community Care Cooperative, or C3 as we call ourselves. We are an FQHC based nonprofit organization, and we are headquartered out of Massachusetts, doing business in Massachusetts, mostly in a Medicaid ACO, but also some Medicare ACO and some commercial, and now have diversified our product offerings to also offer federally qualified health centers, the EPIC EHR, in addition to other shared services. Next slide, please. Next slide. So a little bit of background on health centers and on us. We were formed in 2016 in response to the Massachusetts Medicaid program, which is known as Mass Health, moving from a traditional MCO model to an accountable care organization model. In 2018, we launched the full program with 15 FQHCs and 110,000 members. And in 19, we grew to 17 health centers and 125. And today, we can't quite keep the PowerPoint current. 18 is now 20 FQs. We have about 200,000 members and 3 risk contracts. And as mentioned, we're also now we have licensed the EPIC EHR, which all of you, I'm sure, are familiar enough with the market to understand that the EPIC product hasn't been a hard product for FQHCs to be able to obtain. So we used the same C3 playbook of, if we bring independent FQHCs together, we can leverage our scale to make things possible that have not been possible in the past. This has been true with risk taking on total cost of care in the core ACO business, but also now the other accoutrements that are coming along with this business, such as being able to license down EPIC. Next slide. This is our vision, mission, strategy, and core values. I'm just going to read the strategy. So this is a trifecta strategy for C3. It's focused on uniting FQHCs at scale in order to transform primary care, improve the financial position of health centers, and advance racial justice at health centers, at C3, and in society. Next slide. As a reminder, there is very strong evidence to support that health centers outperform other primary care settings on quality and on total cost of care. This slide is about quality, and it is a reminder that the publicly available data concludes that health centers outperform the rest of the national market on 2 quality measures here. One is patients with hypertension, whose hypertension is well controlled, and people with diabetes whose hemoglobin A1C is being successfully controlled. And then on the last section of the slide is the 3rd quality metric on this slide, which is about patient satisfaction, where health centers also outperform the market. You can see the first line is users satisfied with hours, 96 against 37, FQ to nation. And the second one is overall satisfaction with care, 98 against 87, FQ against national, respectively. Next slide. This slide is complex. No worries. I'm going to talk you through the punchline. I said the health centers outperform the national market on quality and cost. Prior slide was quality. This one is cost. This was a study published in the American Journal of Public Health, November 2016. The study examined 2 cohorts prospectively over time. The study was looking at total cost of care. The study found that the cohort who got their primary care in an FQHC had total cost of care that was about 24% less expensive than the total cost of care in any other primary care setting. This article was actually published right when we were in the middle of starting up the company. So as you can imagine, this was a thesis that we were working off of, and this was very reassuring as we were getting ready to embark on a total cost of care journey. Next slide. So how we got started. Next slide. So this was a group of health centers at the beginning. This was a startup nonprofit. We had $0 in our bank account. And so we needed to develop a plan. And so part of the plan, we were looking at bidding on a 5-year contract that had a total cost of care with corridors that expanded over time. For example, this year, we're in the last year of this 5-year contract. We will renew it. This year, our total cost of care exposure is 100% up, down, 2-sided. We knew going into this, my background is I ran a different ACO for a Harvard teaching hospital system. I ran a Medicaid health plan. I worked in public hospitals, and I worked in FQHCs. So I knew that we needed to have a way to harness lots of different data assets. Some of those data assets have been discussed by other panelists today. Our data assets include, we harvest all clinical data from EHRs at night. We get these so-called ADT transactions, real time, refresh 3 milliseconds throughout the day. We have paid claims files from all of the carriers that we do business with, including Massachusetts Medicaid. We have member self-reported data. We have SDOH data. We normalize and harmonize all of that data in an enterprise data warehouse. And that is the big data set that allows us to do lots of things like a rules-based approach to workflow automation, stratification, performance analytics, research, et al. Next slide. This is just a pictorial of that. The circle is around the enterprise data warehouse, and you can see these are the data assets that are coming in to the enterprise data warehouse: FQHC clinical data, hospital ADT data. We have national feeds from Quest and LabCorp. We have the paid claims data. And as stated, we have member self-reported data. Interestingly, we also do business with a BH carve-out. I wasn't planning on mentioning it, but since it was raised by other panelists, I will mention it. That was a blind spot. We were not getting ADT transactions there. We were able to work with that behavioral health carve-out who issues prior authorizations for inpatient stays, inpatient behavioral health stays. We're able to work with that BH carve-out to translate that prior authorization transaction essentially into a hospital admit ADT ping. So we're able to have a real-time BH inpatient census based on that unique transaction. Next slide. As mentioned, when we were a startup, we had $0 in the bank. And this shows you coming into year one, we had to come up with a little bit over 14 million in order to prove to our regulators, and in Massachusetts there are many financial regulators, that if we had a bad outcome on this total cost of care contract in terms of incurring deficits, that we had the financial wherewithal to repay those liabilities. And so we used a multifaceted approach to be able to sort of have a portfolio strategy to skin the cat on coming up with that 14 million, as displayed here in this waterfall. So we bought excess loss insurance that covered about 5 million of that. We have a system of responsibly sharing risk with our provider organizations, our FQs. We're going to talk about the details of that in a moment. That moved 5.5 million off of our balance sheet. We had a partner who was offering us a service, a vendor who was willing to take a little bit of risk that underwrote about $1 million. That left us with 2.7. The contract with Mass Medicaid did come with some financial support, and we were able to meet that 2.7 through the contract. This was good enough for our actuaries to sign off on our repayment mechanisms and to pass muster with the many regulators, including Mass Medicaid in Massachusetts. Next slide. Similar to other panelists today, we also have a model of care, 4 core components, a lot of detail, of course, within the 4 of these, not planning on talking about them today. Of course, happy to take any questions on our areas of practice transformation, pop healthcare management, and the miscellaneous things we do. I would say of all of the things that we do, focusing on closed loop referrals for social determinants of health and practice transformation are probably the most existentially powerful in terms of trying to make real change in this local healthcare ecosystem. Next slide. So I'm going to move to wrap up now on how it's going. Next slide. As you can see here, things have been good for us financially, and we've outperformed the market. Next slide. The growth in our balance sheet, you know where it started. It's at 55. I think actually right now it's at 58, so things are good. Next slide. Growth in membership has also been excellent. Next slide. As mentioned, we have these other business lines, Epic and Pharmacy Services. Next slide. Next slide. In closing, I would say we'll make this the last slide, that we agree that getting off of the fee-for-service chassis is existentially important. Is primary care capitation perfect? No, it is not. But all of our health centers very much agree that it is a more progressive way to embed prospective payment, even if it's not a prospective payment on the entirety of total cost of care. So we are moving to primary care capitation. We hope to have 80% of our visits in primary care capitation by the end of next year. Thank you very much.
Thank you so much, Christina. It was very.
Thank you so much, Christina. It was very.
As our last presentation, we now have some representatives of a previously submitted proposal to PTAC. We have John Broyles, CEO of the Coalition to Transform Advanced Care, Gary Backer, Chief of Strategy, Policy, and Legal Affairs, Capital Caring Health, and Tori Fields, Chief Executive Officer of Votive Health. CTAC submitted the Advanced Care Model, ACM Service Delivery, and Advanced Alternative Payment Model in 2017. Please go ahead and remember to unmute yourself as you present.
Thank you. I'm going to do some framing at the outset and then turn it to my colleague, Gary Backer, who was part of the team from 2017 that submitted and spoke before the PTAC. CTAC is a large alliance of nearly 200 organizations. You may not know CTAC, but you likely know our members, AERP, American Heart Association, American Hospital, large systems, and health plans. And our focus is on transforming the experience of the patient and family from the point of diagnosis through to the end of life. So we're here speaking on behalf of the patient and family. Next slide, please. So our story today begins, from 2017, where we were last before the PTAC, and 2 things happened after that. One is you asked a lot of great questions, tough questions that helped us refine our proposal. We worked with the American Academy of Hospice and Palliative Care directly with CMMI to advance the key elements of the proposal that we reviewed with you into new payment models, and heavily informed the CMMI Primary Cares initiative. So, number one, thank you for your feedback, and know that you are having impact. The second thing is that we had a realization that, as sophisticated as the model of care that we submitted was, it wasn't enough. And so next slide, please. Because to really reach those who are completely outside the system, we have to work not just through Medicare eligible providers, but really intentionally in partnership with the community. And that brings us to the story of Shirley Roberson. Shirley was a colleague of mine, a friend, in fact, and recently a board member of CTAC. She lived with advanced cancer for over a decade. And during that time, she really taught us that trust is key. The relationship with the patient is key to this entire discussion around total cost of care. And really, it was during many ups and downs, many challenges with social isolation, challenges with transportation, food, pain for her, that her cancer was causing, that her faith community really stepped up. And Shirley would often say to me, when you feel like giving up, it's the community that's going to keep you going. And that's always stuck with me. And now she thought of community as including her oncologist, who would not just help her with her pain, but also remember to give her a hug and check in and see how her art was doing. But it also included the Area Agency on Aging. It included her church, Hartford Memorial Baptist. And I think as we think about where to go next, where the greatest opportunity for innovation lies, we believe that it's in reaching those who are completely outside the system, those who have been underserved for too long, and those who need investment in trust and trusted relationships. So as we think about how to get there, we have to think seriously about investing in the organizations that folks like Shirley believed in, not just as a charity, not just as community benefit, but as true partners as we move this $4 trillion health system that we have towards more person-centered care. And I'm going to turn it to my colleague, Gary Backer, to talk about some of the practical elements behind our recommendations there.
Great. Thank you, John. So thank you again for having us. It's a pleasure to get to come before the panel again. As John mentioned, we got to do this a few years ago. There's a couple of important themes to pull through that came from the earlier discussion with the PTAC, and I had the pleasure, following our PTAC presentation, actually become the Chief Strategy Officer for CMMI and helped oversee the architecting and development of a wide range of the models that are being used today. And I think there's two important themes that emerge kind of from the conversation we had with the PTAC earlier and part of our work today. So one is we're strong believers in the power of total cost of care for a lot of the conversations that have been conducted today, but it's also important to ask about total cost of care for who, and to think about the different subpopulations that are being served under any particular model to make sure that things, in a sense, don't get over average. So paying attention to important subpopulations, not necessarily carving them out, but being aware in model design that if you're taking care of a substantial portion of people that are of a particular subpopulation, it may be important to kind of make sure that the model parameters are flexible enough so that it can accommodate those populations and make it feasible to successfully serve those people. Second point has to do with nested models. And I say this all the time. One of the things that I remember from the PTAC discussions before was the discussion around, does it make sense to have broader nested models or standalone models? And the idea, as we talked about at the time, we were proposing a model to focus on the seriously ill, which really did inform a lot of CMMI's work. And one of the discussion points was, well, why would you want a standalone model to focus on the seriously ill if we already have many longitudinal total cost of care models where their incentives should already be in place to actually focus on the seriously ill people with advanced illness? And we thought, and we still think, that that's actually a very, very valid point, but there's also some issues where if you build it they won't necessarily come. And so one of the questions is, how do you really have the right balance between broader population-based models where you are creating the right incentives or even minimum requirements to be able to offer certain kinds of services, a minimum of services, for instance, that should be used to make sure that everyone with serious illness receives the right care? How do you do that in balancing between a nested design where you have that as part of a broader longitudinal model versus a standalone model? And our view is, in general, you should try to avoid, and I'll use the term disintermediating, those that would be taking total cost of care and total quality responsibility for a population, but at the same time, you want to make sure that there are, for those patients that are not going to be aligned to some kind of a longitudinal model, that there is, for instance, a standalone opportunity so they can receive services that are important to their care. And then another point that we've taken away is really systematically identifying and addressing and assessing populations' needs. And John made this point very well, the importance of actually focusing on those around people that are giving them the support. And so really honing in on caregivers who do amazing work, but recognizing that they suffer a great burden. And how can we in the different models actually, for instance, do a better job of supporting caregivers? And that leads to the final point, which is how do we do a better job of bridging the divide between healthcare and the community, the divide that John spoke about. And if you think about our models, most of them really have a sort of a medical provider construct to them. So very typical in a model, there'll be a participant provider and a preferred provider, but we don't really have formal room for the community in our models. And so beginning to think about how do we do that and how do we actually create new infrastructure on the ground. Sometimes we refer to it as a hub or a marketplace where we can, for instance, bring together healthcare organizations and community-based organizations and provide support for those community-based organizations, whether it's with contracting or data management and reporting. And then finally, the one hard issue we're going to have to address is ultimately how do we pay for these services? Because if we're talking about Medicare beneficiaries, Medicare has a big gap in terms of its coverage. And that's because it really doesn't pay for non-medical services. It doesn't really have a clear payment stream for services that meet people's social determinants of health. It doesn't have a payment stream that meets what in the Medicaid world we would call long-term services and supports, and it doesn't really have payments for long-term care. And so we really have to begin to figure out, given those deficits and those gaps, how do we, for instance, find ways to pay for services that would close the gaps that people have? And a lot of that, I think, begins with bridging the divide between the healthcare world and the community. So with that, I'm going to turn it back to the panel. Thank you very much for having us.
And I'll just say to end our presentation that we've included 2 emerging community-led models that are partnering with health systems in the appendix of our slides, the Alameda County Care Alliance and the Coalition for Serious Illness Care in Arizona. So thank you.
Thank you so much, John and Gary. You can tell from these presentations, we've covered a lot of really rich and interesting ground. I'm going to open it up now for the committee to ask questions. You can raise your hand to be added to the queue, but please go forward, committee members.
I'll start. John and Gary, as I recall your 2017 proposal, one of your objectives was to break down the silos between curative and palliative care. Have you been able to accomplish that in the work that you've been doing in the places where you're operational?
It's a great question, Bruce. I'd say it's a ongoing journey, but we have made lots of progress, and we'd like to share what we've learned with you. I turn to Gary to comment, and then we also have our colleague Tori Fields, who has been working on this issue really closely at the operational level. And Tori, maybe you can speak to this after Gary.
So one thing I'll mention is there's actually a couple of the models that CMMI has put in place that directly address the idea of concurrent care. So two examples of that would be in both direct contracting, what will become the REACH ACO model, and then also in the Kidney Care Choices model, there's actually a concurrent care hospice waiver. And a lot of that inspiration really came from the idea that we should be looking at ways to make it easier for people, if appropriate, to be able to access hospice. And a lot of that, there's also has been the Medicare Care Choices model, or MCCM, which was designed to also sort of test what's the effectiveness of being able to provide people some degree of conventional care in addition to supportive care. So there's actually been several models that have moved in the direction of trying to provide more flexibility for concurrent care. And I think it'll be really important to see what those lessons are. So in the CKCC model and direct contracting model, the KCE or the DCE can allow the beneficiary to continue having Medicare pay for conventional services while the beneficiary actually elects hospice. And that's one of the waivers that's built into each of those models. But John, I'll turn it over to you and Tori to provide some additional perspective.
Tori?
Sure. Thanks for having me today. My background is largely in the private sector and also in the Medicaid managed care space. And from that perspective, there's been a lot of movement since 2017, really looking to build out more holistic models and concurrent models for people with serious illness. So the Blue Cross Blue Shield plans have spent a lot of time really working on this and embedding palliative care services or advanced care planning into their accountable care organization models to require that these populations are then assessed for different services and are actually being delivered those services like palliative care and hospice. And those models are largely on a sub-delegated arrangement where there is an ACO who is actually paying a per enrolled member per month for those services, and they're included in total cost of care. There was a paper that just was recently released about the California model, and the 5 health plans who actually delivered palliative care services across this model all saved money, but also improved population outcomes. They also proved that you could have a multi-payer collaborative across a state and do the same thing. So I think that's also worth noting. On the Medicaid side, there are now 2 states who are implementing palliative care benefits as a concurrent care model, both for adults and for kids, California being the first one that did that on a state mandate through legislation. Hawaii is working now on submitting a state plan amendment that includes palliative care as a benefit. If that gets approved, then there are multiple state Medicaid programs who are looking to do the same thing. And as part of that, what we have to do, and what my team has done for some of those state Medicaid agencies, is to actually look at their total population, stratify them based on their risk and their need, and actually look at that seriously ill population differently to determine what the gaps are in their care. So there has been a lot of momentum and movement on the private side. And as Jerry was saying, in the model side, the value-based insurance design for hospice is also an additional place where the carve-in is being tested, and health plans are testing palliative care services with that.
Thank you so much, Tori. I'm going to go next to Larry Kaczynski with his question.
Thank you. I have a question for Belinda. The CCM codes have not had traction for their entire existence, but there was a change in last year's final rule that opened up opportunities for PCM codes. Mm-hmm. And we're seeing independent companies develop products now around the promotion of PCM codes. So we should expect to see an increase in their use. The problem I have with this, these are not first dollar claims. The patients are going to be hit with deductibles and copays on them. And I don't know how you place, and I'm interested in your input, I don't know how you insert a PCM or CCM code into the chronic care of a patient when they're going to get hit with monthly copays and hits on their deductible. I just don't see it as a solution.
Right. There have been several medical associations, and certainly APG was one of them, in which we pushed for CMS to not have that be one of the copays, like annual wellness visit. Do you know what I mean? It's not a copay, and yet it's classified, Larry, under that. If you look under clinical code services, in which you have ACP, advanced care planning, TCOC, CCM, annual wellness visit, you are exactly correct. That should have no copay. I think that is an opportunity for advocacy. I do know that there are some physicians that have said, I feel guilty, doing a CCM code and charging the patient 20%. We have found there is success and decrease, do you know what I mean, in hospitalizations and readmissions using the code. So you're exactly correct. I think it is an error of CMS not to have it on one of the list of no copays.
Thank you so much, Belinda.
If I may add, Belinda, can I just add on the advanced care planning component of that, the copays have been a huge deterrent for people with serious illness. And what we're finding is that 50% of the population who have an advanced care planning billing code dropped is by a specialist outside of the annual wellness visit. So the initial intention of trying to couple these things with primary care or an annual wellness visit just really have not worked out.
Mm-hmm.
So helpful. Chinny, you're next.
My question is for Christina. You spoke about sort of some of the quality as well as economic value in the organization. And what I wanted to ask is what is your strategy for managing specialists as well as post-acute spend, and how do you bring them into your total cost of care methodology?
Yeah, figuring out how to engage specialists in the total cost of care methodology is a difficult nut to crack. So I will not tell you that we have completely solved that. I would say that when we look at the patient population, the needs of the patient population, the resulting spend pattern by major category of service, that the majority, because in our biggest ACO product line, which is Medicaid, of course, in Medicaid, 80% of what shows up as healthcare need is not sort of pathology, not clinical pathology based, it's not about physical health. That in some respects in the Medicaid population, some of those really difficult to solve issues with specialists are slightly less germane. Probably the best example is the need for access to the specialists under the behavioral health umbrella. This is a place where health centers and organizations like health centers have some advantage because there is a lot in the behavioral health outpatient continuum of care that may reside inside of the FQHC. Access to ongoing therapy, integrative behavioral health clinicians and psychiatrists who do prescribing, that it's all part of primary care team. So that sort of building out what lives under the house of primary care and making that increasingly expansive has been a good way to address some of these specialty issues by no longer really classifying them as specialty and bringing them into the primary care home. Another idea that we have been working on and we're testing with regards to all of the other specialists is the use of telehealth, both e-consult, so asynchronous e-consult, where it's clinician to clinician via email, essentially, using e-consult as a primary modality to get the need met around specialist care, with, of course, then an exit ramp for individuals who need face-to-face specialist care immediately, or where the e-consult has determined that the patient now needs a visit with the specialist. In certain markets, the other thing that we've been able to do when we find that there's a significant difference in the quality of specialty services is redirect care over to a different system. This is not done through traditional methods of network management or prior authorization. This is really done with speaking with clinicians and having clinicians develop different patterns of referrals based on where they are most comfortable having their patients go. Getting back to the issue of trust, we find that the best way to advise patients, to have patients go to preferred specialists, if you will, is through the clinician, the PCP, the behavioral health provider, the nurse practitioner, et cetera, having more of a clinical comfort with those particular specialists and developing those relationships.
Thank you so much, Christina. Walter, you're next.
Thanks, Lauren. So this is a question for Belinda. Belinda, on your solution slide, you mentioned the idea of curating a central repository, which is actually very timely, as this committee was only this morning discussing the development of a library of care transformation and practice redesign best practices garnered from other disease-specific and episode-based payment models like the oncology care model and the ESRD care model. My question is, how has Upstream populated its central repository with strategies and best practices and disseminated these practices to its participating providers?
Yeah, so I'm going to defer the question since I've only been in Upstream for a month. Okay, so can you ask me that question in about 6 months? Okay.
Fair enough. Okay, thank you.
I can answer it from a APG perspective that we tried through a lot of webinars and having a central repository in the website to be able, because a lot of our members were independent practices and they had very little access to know what was working. They weren't a part of large organizations that big health systems could purchase, to be able to go in. So we tried to provide that, but certainly having a national database that would be open to everyone would be optimal.
Thank you, Belinda. Jennifer, you're next.
Thanks to all of our presenters for excellent presentations. My question is going to be for Christina, although a number of you have talked about this issue. My question is around, Christina, impressive results with your organization. And being a risk-bearing entity, I was wondering if you could address the two specific concerns that we've heard regarding barriers to participating in total cost of care programs. One is the infrastructure cost. So you describe an impressive data analytics program and plan, which I'm assuming required a lot of capital. And then also this concern around diminishing returns in a program around performance and how you thought about those, not only in developing your program, but also in maintaining the successes you've seen.
Yes. So on the first one, barriers to entry because of infrastructure costs. There are definitely infrastructure costs. I would say initially for us, based on our scale at startup, we had to spend approximately $5 million in building infrastructure. One of the ideas that we have put forward, and this comment is particularly relevant to entities in the healthcare market who have traditionally had less access to capital, because perhaps they are a safety net organization, or they are a 501c3, or there have been other constraints on building up the balance sheet, that some of these programs, both local programs that might be run by local Medicaid authorities or commercial carriers, or federal programs, also come with startup capital. When you think about sort of the intricacies of risk-based capital and requirements that the Department of Insurance will have on an HMO, this is based on how much risk the HMO is bearing. When an HMO gets involved in doing business with a provider organization on total cost of care, this is a risk transfer. So I think that one could argue that a source of startup funds for building infrastructure would be the health plan sort of having a redistribution of the risk-based capital that has been held against that account before it was a total cost of care risk account over to the provider organization who wants to enter into risk as in capital investment in that organization's ability to build their infrastructure. On the second point around the law of diminishing returns for high performers, it's a really, really important point. In the Massachusetts Medicaid program, the state has taken some very good steps, not that it couldn't go further, and we advocate for it going further, in having a market blend into the development of benchmark. So that if we are beating the market, right, and we're managing down our own experience, that we have a way of having a blend of our experience with the average cost of what's happening in the market, so that it has the ability to lift up our budget. This has been critically important to us at this point in the program, given our success. If we could choose, we would choose a purely market-driven rate. So I think that that is a way for that to happen across the board, locally, nationally, public payers, private payers, to be able to have higher performers choose between experience-rated benchmarks or market-rated benchmarks or a blend.
Thank you so much, Christina. We have one more question from Paul. This has been really rich discussion. I'm sure we could talk for hours. But Paul, can you ask our final question before we go to the break?
Yeah, thank you. And I also want to thank all the presenters for just great presentations. This question is for Belinda. And Belinda, I know, well, first let me say I'm grateful of your work for BPCI because in my former role, leading population health in a tertiary community hospital with multiple specialty groups, I saw firsthand the engagement of the specialties in BPCI, the classic, and then with advanced. So I think we've learned a lot, absolutely. So now as we're thinking towards these population-based total cost of care models, and I know you've been involved in some of these listening sessions, and I'm sure you've been thinking a lot about it. I guess my question is still, from your perspective and in your roles, how best to engage specialists going forward as we move to these larger total cost of care models?
So, Paul, I really believe that episodic payment models are the best for specialists, and you need them, or you're just not going to get the level of engagement that you need in terms of moving them to value-based. Total cost of care models is the ultimate way that we need to be there. I have recommended that they really look at lessons learned, particularly in APG. We had a lot of members that were out in California that had had decades of experience in terms of taking capitated delegated risk in the MA population. And as they took it, they started with different relationships with the specialists. The specialists, they would do things like, you had to meet a time, a framework, or a service, or patient satisfaction to get on the list. And they found that that was just not enough, that they actually had to figure out a way to subcap it or look at a bundle, a payment with them. And I have recommended to CMMI that you take the lessons from that. And so whether that ends up being a nesting, does it end up being something that's a blend of both? But certainly I think the specialists need to have, one, an episodic payment to be engaged, and two, the overall platform in terms of total cost of care they are not engaged in an ACO. So somehow I think take the lessons that have decades of experience in subcapping and having the specialists be their partners in that and not treat them in terms of commodities. And unless you achieve these service goals, we're going to kick you off the list. You know, that didn't work. It doesn't work with anyone. People want true partnerships.
Thank
What a
you.
great note to end on. Thank you so much, Belinda. My great thanks to each of you, each of our experts, for sharing your time and experiences with us. At this time, we'll take a break until 10:15 a.m. Pacific, which is 1:15 p.m. Eastern. We'll return with a roundtable panel discussion, and I hope to see you then. Thank you all so much.
Produced by the U.S. Department of Health and Human Services.